Assalamu alaikum wa rahmatullahi wa barakatuh. This is the last lecture in Oral Pathology 2, and it is about diseases of the temporomandibular joint. In general, the diseases or disorders of the temporomandibular joint are more extensively discussed in oral medicine and oral surgery courses. In the oral pathology, we will limit our discussion to these groups of lesions. We'll talk about arthritic disorders, arthritic meaning joint-related disorders, rheumatoid arthritis, ankylosis, temporomandibular joint disorders, or as it is known, TMDs, loose bodies of the TMJ, developmental disorders, and neoplasms. Okay, the arthritic disorders affecting the TMJ includes osteoarthritis and osteoarthrosis, and we will discuss now the difference between these two when we call it osteoarthrosis and when we call the condition osteoarthritis. Rheumatoid arthritis, the autoimmune systemic condition or disease, it will affect TMJ as part of this disease. Septic arthritis, meaning that there is bacteria or infective organisms reaching the TMJ and causing signs and symptoms. And ankylosis, which is adhesion of the joint elements. All of these 4 points or 4 conditions are related to the arthritic disorders affecting the TMJs. First, what is the TMJ? It is a synovial joint. It is one of the rare body joints that have 2 joint compartments. You know, there is upper compartment and lower compartment separated by the disc or the articulating disc. The condylar head and the glenoid fossa, both of them are lined by fibrocartilage. These are the articular surfaces. Okay, so looking here, we see that this is the mandibular head and this is the glenoid fossa. And here we find the articular tubercle, which is located anterior to the glenoid fossa. This is the mastoid process, and this is the articular tubercle. Articular tubercle will limit the movement of the condylar head anteriorly. We have this joint space bounded by the mandibular fossa superiorly and by the mandibular head inferiorly. The glenoid fossa and the mandibular head are lined by fibrocartilage, and they are separated by the articular disc, and we have upper compartment and lower compartment. I'm sure you have taken in the anatomy course the articular disc attachments anteriorly and posteriorly and the boundaries of the TMJ. Now we will start talking about the arthritic disorders, starting with the first 2, osteoarthritis and osteoarthrosis. Both of these are degenerative changes. Actually, they are combined under the term degenerative joint diseases. Okay, so osteoarthritis, osteoarthrosis, both are degenerative. There is degeneration in the joint. These degenerative joint diseases are diagnosed clinically when we have crepitus. Crepitus is not the click. If you go back to the oral diagnosis lectures, crepitus is when you have a sound like 2 rough surfaces rubbing each other. It is not a clear popping of a sound. Okay, it is like 2 rough surfaces passing over each other. Okay, crepitus with or without pain. I will tell you from now the difference between these 2. If we have pain, then it is arthritis, meaning that there is inflammatory process in addition to the degeneration. If there is no pain, then we will call it, there is crepitus without pain, go to the other term, osteoarthrosis, meaning there is degeneration leading to this crepitus, but there is no active inflammation or inflammation or something causing pain. So there is no pain. Osteoarthritis, a degenerative condition affecting mainly the knee joints, rare in the TMJ, and usually it is related to trauma. Trauma will accelerate these degenerative processes. Now, with the degeneration of the articular cartilage that is lining the glenoid fossa and the condylar head, if the cartilage is gone or is degenerated, there will be bone erosion. And after the loss or the degeneration, there will be a reactive response from the body. There will be new osteocartilaginous proliferation, again, from the area where the erosion occurred. And in this area, osteophyte will appear. What are the osteophytes? The osteophyte is a projection of bone and cartilage. Okay, and this occurs at the periphery of the condyle. So let us put it again and say it again. First, we have loss of the articular cartilage. As a result, the response is to proliferate and try to make a new articular cartilage. Okay, now during this proliferation, there will be formation of something called osteophyte, which is the osteocartilaginous proliferation. This osteophyte will project into the joint space, and this osteophyte might break down within the synovial space or the joint space in the form of loose bodies. We will talk about loose bodies in the coming slides. And I will say that loose bodies can be this and this and that. And one of these things that the loose bodies can be are the osteophytes, which are a component of the degenerative conditions. Okay. The second condition, which is the autoimmune disease, it is inflammatory condition of the synovial lining of several joints in the body. It's, as I said, autoimmune disease. It is called rheumatoid arthritis. In general, rheumatoid arthritis will affect the joints into 3 inflammatory phases. The first phase is just non-specific inflammation. The second phase, there is activation of the T cells. So now the inflammatory component or the autoimmune component is strong, to be followed by chronic inflammatory phase. In chronic inflammatory phase, there will be destruction of the bone and cartilage. How? Due to the different cytokines. We have autoimmune condition, we have chronic inflammation, we have a lot of, let us say, disturbed activity of the immune system. So you know that there are a lot of cytokines and interleukins, and these cytokines and interleukins will end up by destroying the cartilage and the bone. So what will happen is, in rheumatoid arthritis, your patient might come with crepitus, just rough sound and noise in the joint. Stiffness and limitation of the opening. The patient cannot open due to pain, maybe. Referred pain, tenderness on biting, severe disability. But the severe disability in joint movement is minimal. But usually your patients with rheumatoid arthritis will have systemic symptoms and findings, and he will be already diagnosed with the rheumatoid arthritis. So you can easily correlate these clinical features with the patient's body condition or systemic conditions. What are we going to see microscopically? The synovial lining that is affected by the chronic inflammation and autoimmune condition will be under the influence of the interleukins, okay, and cytokines. So it will proliferate and it will form granulation tissue projections inside the synovial lining or the joint space. Do you remember in the case of osteoarthritis and arthrosis, the degenerative conditions, we said osteophyte, the bone will proliferate, while here the lining, the soft tissue lining will proliferate through granulation tissue formation. And there will be destruction of the underlying cartilage and bone and erosions and resorption and due to the cytokines effect. How is rheumatoid arthritis treated? It is treated by anti-arthritic drugs, and they are beyond the scope of our lecture. Here, the joint involvement. Let us look at this synovial. Okay, this is the capsule, and this is the synovial membrane. Synovial membrane, okay? It is inflamed, it is red in color here, and it is having villus formation. What does these villi what do these villi contain? They contain granulation tissue. They are composed of granulation tissue due to the inflammation. There will be resorption and destruction also of the bone within the joint. Okay. Here also another example, again look at the villi that are projecting into the joint space and the granulation tissue formation projecting into the synovial space also. Okay, now in the case of septic arthritis, meaning that there is infection by microorganisms, mainly by bacteria like Staph aureus, and usually or most likely the spread of bacteria will come from the hematogenous spread, meaning there will be a systemic spread and it will reach the TMJ as part of the another body condition or another infection somewhere else. Now, because we have active infection, you will have painful joints, there will be trismus of the surrounding muscles, there will be deviation on opening. Why? To avoid the pain in the affected joint. So the mandible will deviate to avoid that painful feeling, and there will be signs of acute infection. So the whole picture together is that of acute infection. And if aspiration was performed, the fluid that can be aspirated is thick and yellow. It is like pus because it contains a lot of neutrophils. What is the prognosis and the complications of septic arthritis? It might heal uneventfully, or it might result in fibrous or bony ankylosis of the joint. So there will be long-lasting disturbance or a change in the joint range of movement. Ankylosis can result from several conditions. It can result from infection, can result from osteoarthritis, from other long-standing arthritic diseases, from trauma, or even from the mastoid air sinuses or air cells infection, because the mastoid sinus, you know that the mastoid bone contains mastoid air cells. It is like the paranasal sinuses, and it can get infected. It's close to the TMJ, so the infection can reach the TMJ. So as a result of any of these conditions, the patient might get an ankylosed TMJ with severe limitation in the jaw opening. Treatment, joint replacement. Now, a group of Temporomandibular disorders. They are known as TMDs. Okay, these TMDs are 12 in number, and they are categorized as in the next slide. It is from your 5th edition textbook, Sounds and Southam Oral Pathology. They are categorized there into 4 categories: myalgia, meaning the muscles, arthralgia, intra-articular disorders, headache attributed to TMDs. We will not discuss TMDs in the oral pathology course. They will be discussed and covered thoroughly in the oral medicine courses in both 4th year and 5th year, and in the seminars of oral medicine. You will also discuss them in details in the oral surgery courses. So in oral pathology, we will just quickly go over them. I will tell you that the signs and symptoms you can identify include joint noise, crepitus pain, headache, alteration in the range of joint movements and the jaw movements, and the management is usually conservative. They will give them NSAIDs, reassurance, they can give them physiotherapy, they can get occlusal splints and alterations in the diet. Okay. Some disorders that are uncommonly seen in the TMJs include synovial chondromatosis and condylar hyperplasia and neoplasms. In synovial chondromatosis, we will not talk much about it, but we will know that it is a disease of unknown etiology. There will be formation of multiple nodules. So these loose bodies are multiple nodules of cartilage that are released into the synovial space, and they can limit the movement. Radiographically, they can appear like loose bodies floating into the joint space. Okay, they are rare in the TMJ and common in major joints like the knees. They can cause limitation in the movement, pain, and crepitus in the joints. And the main causes of loose bodies, as we said, one of them are osteophytes, fractured osteophytes. You remember that osteophytes were mentioned in degenerative joint diseases, osteoarthritis and osteoarthrosis, and they can get detached and float into the synovial space. And now we have mentioned synovial chondromatosis, although they are rare in the TMJ, but they still can occur, in addition to fractures from the articulating surfaces within the capsule of the joint. And finally, or just before the final topic about the TMJ, is the developmental disorders of the TMJ. We have discussed this in details when we took the chapter of developmental changes of the bone. We mentioned condylar aplasia, hypoplasia, and hyperplasia, and we discussed how the clinical appearance of the face will be and how the deviation of the mandible will occur in these conditions. Finally, we will talk about neoplasms. And since we are talking about TMJ, the components of the joint will include synovium and bone. So the tumors arising from this kind of tissue will be sarcomas and not carcinomas, because carcinomas arise from epithelium, while sarcoma arise from connective tissue. So if the tumor or the malignancy will arise from bone, then it is called osteosarcoma, as you know. And if it will occur from the synovial tissue, it is also type of sarcoma. But however, the benign tumors are more common than the malignant tumors in the TMJ. Benign tumors include chondromas and osteomas. And by this, we reach the end of the lecture about TMJ, and this is the end of the last lecture in the course of Oral Pathology 2.